Welcome back to the channel, everybody. This case is a manual small incision cataract surgery, M6, being done for a brunescent cataract following a penetrating corneal trauma many years ago. So we're dissecting conjunctiva and now we're cutting tenons. That exact tissue that has been cut now is tenons, and we're creating the conjunctival opening to be able to create the scleral tunnel. A very mild cautery is necessary just to have good enough visibility. You don't need to turn the sclera white. That actually makes things worse. It induces a lot of ischemia. The only point of inducing cautery is just visibility, and maybe you can drag some bleeding inside the AC if you don't perform enough cautery, but that's not really the issue. So about 1.5 millimeters back from the limbus, we start our linear corneal scleral tunnel, which we initially dissect with the crescent blade centrally up until maybe 1 millimeter inside clear cornea, so that the tunnel itself has about 2.5 centrally, and then peripherally we go way out and the tunnel is much longer in the periphery than it's in the center, and that actually offers structural integrity to the tunnel. M6 has two caveats, 2 points that the surgeon needs to be aware of, and the first one is the tunnel creation. To avoid premature entry into the AC, that would be one of the bad complications, because you may intersect the iris root, you'll maybe get uveal incarceration in the scleral tract, and that's very nasty, so you need to avoid that. And the second thing that you need to be aware of during M6 is to be able to get the nucleus out of the bag and actually in front of the iris. Many cases where you might consider doing M6 usually have long-standing cataracts that also associate a bit of zonulopathy, a bit of non-dilating iris, and many things that will make the surgery difficult. So if you don't want to lose the bag during M6, which is a likelihood that has happened to all of us, you need to be more willing to use hooks if the nucleus simply doesn't want to come out. Or if the visibility is poor, you need to do everything you can to have the extraction process go very smoothly, and the rhexis needs to be very, very big. You don't need to worry about that 5.5 millimeter sizing that you get in phaco. M6 is more about safety than it is about refractive outcome, so large rhexis is always better and makes the surgery faster, more efficient, and safer. So after we do the rhexis, we enlarge the incision to the final size, and then we use that incision to perform the hydrodissection. And during the hydrodissection, your goal is to actually pop the nucleus out of the bag. If you can do it now, it's best. And out of the bag and in front of the iris, so completely into the anterior chamber. In this patient, you can appreciate he has a focal opacity that we've rotated to the left side of the screen. The focal opacity has to do with the penetrating trauma that he had many years ago. And this nucleus isn't that big, so for our usual M6 cases, this nucleus is reasonably sized. Then we use a non-irrigating vectis to sneak it underneath the nucleus, and then with simple dragging and maybe posterior pressure on the lip, we get the nucleus out. You never ever want to pull up on the nucleus. That is sometimes during the learning curve your impulse to try to drag it out. You never want to do that. You will induce a lot of corneal damage that you cannot repair without a transplant. If the nucleus doesn't want to come out, you simply need to enlarge the incision until it does. And that's the only thing you can do or should do. Refill with viscoelastic and enlarge the incision. Sometimes the diamond keratomes are not adequate for enlarging these very long incisions, and you maybe need to use a steel keratome or even a larger millimeter keratome, like a 4 millimeter. You can find those in many operating theaters. And here we can see that the rhexis, in our case, is no longer intact. It probably wasn't intact to begin with because he had a penetrating trauma. And you can observe that we have a flap of anterior capsule that is dangling very near where we also have the iris defect. But still we need to get all of the cortex out. We just need to be careful that when we're grabbing the cortex to pull it, we don't also grab capsule. So now we're using the vitrector to trim off that flap of capsule so it doesn't get in the way visually, but you can also appreciate that it's kind of stuck to the iris there, so we want to do that as limited of a cutting of the flap as possible. We don't want to induce more iris defects. So the injection of the IOL can be done, the insertion can be done without an injector, without a cartridge, because the incision is so large, but you kind of have to use viscoelastic for this process. And then sneaking the haptics in the bag is perfectly doable, even if the rhexis is big. And in these cases, we always prefer 3-piece IOLs because they will stay in the bag even with the very big rhexis. And suturing of the incision is necessary or not depending on the architecture. If you want to have safety, just put in a few stitches. We like to use these running and coming back stitches. So we do the first pass to the left and then we jump all the way to the right and then come back to have the knot done. And these are just 3 passes and it looks like a double X and looks kind of nice in the post-op period and offers very good closure and low astigmatism. You don't always need to bury this knot, just trim it enough so it doesn't poke out of the conjunctiva, and then be sure to take out all of the viscoelastic because this surgery induces enough inflammation as it is. You don't usually get corneal edema because there's no manipulation happening with the phaco probe, but you may get inflammation because of the fact that the scleral wound is so big. And then just check for no leaks, and that's the surgery. Thanks for watching.